السلام عليكم. The clinical consultation day. First scenario, Mrs. Julia Adam, 45 years old, had uncomplicated myocardial infarction 5 weeks ago. Now, patient feel lethargic. Please take history and examine the patient, address her concerns. Okay, ready, Dr. Azza, Dr. Rasha?
Yes, Dr. Basim, okay.
Yes.
Okay. Here you go.
Hello, my name is Dr. Azza Mustafa. I am one of the doctors in the clinic today. May I confirm that you are Miss Mona, 45 years old?
Yes, I am.
Okay, Miss Mona, we are here today to discuss issues related to your health condition. I may examine you and I'll try my best to address your concern. Is that okay with you?
Yes, doctor.
Okay, can you tell me what brought you to the clinic today?
Yes, doctor. Recently, since 1 week ago, I feel also I feel lethargy.
What do you mean by lethargy?
Yes, doctor. I feel fatigue and also I feel dizzy.
Okay, you mean dizzy like surrounding are turning around you or you lose conscious?
No, doctor. I am not lose consciousness.
Okay. How did it start? Was it sudden or gradual?
It this week started gradually.
Okay. Do you feel that anything that make it worse?
Like what, doctor?
Like exercise,
No.
like standing from a lying position?
Yes, doctor. I feel dizzy when I try to stand from the sitting position.
Okay. Do you notice anything that make it worse?
No, doctor.
Anything make it better?
But when I feel lethargy and dizziness, I try to take some medication for my heart, but I think there's no any improvement.
What medication?
Yes, the doctor described to me some medication with the called nitroglycine, but I don't feel any improvement after take this medication.
Why you take this medication this morning?
Yes, doctor, because recently admitted to the hospital because I have heart attack.
Okay. Did you go any procedures?
Yes, doctor. The doctor said to me I have blockage to my blood channel. For that, admitted to the hospital and do some procedure to try to open the blockage. And also, the doctor said to me there's both some material to keep the blood channel is open. I think which is the called stent.
Okay. Okay, Miss Mona, sorry for what happened to you. We're going to help you. Okay, Miss Mona, do you feel anything rather than this dizziness, like becoming paler than before?
No, doctor.
No. Okay. Do you feel any heart racing?
Heart racing? No.
Any chest pain?
No.
Okay. Is there anything like blood losses from your body, like from your nose or from your back passages?
Any blood? No, doctor.
No blood. Okay. Do you have a balanced diet? Do you eat well?
Yes, doctor.
Okay. Okay, Miss Mona, can you tell me if you have any headache?
Headache? No, doctor, but I feel headache when I took the medication nitroglycine. I feel some headache.
Okay, Miss Mona. It's the same period, 1 week.
It's what?
The same period, 1 week.
Headache, yes, but I think, doctor, when I took this medication, I feel headache.
Okay. And for how long do you take this medication? Only for 1 week, or you take it 5 weeks ago when you had this MI, this heart attack?
No, doctor, when I start after discharging to the hospital, I took this medication.
Okay, Miss Mona. Do you feel any weakness in your body?
Weakness? No.
Okay. Any numbness or tingling?
No.
Any hearing difficulty, any vision problem?
No.
Okay, do you have any mouth sore?
No.
Difficulty swallowing?
No.
Tummy pain?
No.
Tummy distension?
No.
Any shortness of breath?
No.
Any cough?
No.
Okay, do you have any high body temperature?
No.
Any sweating?
No.
Any moody changes?
No.
Any weather preferences?
Use what?
Weather preferences?
No.
Weight changes?
No.
Any joint pain or muscle pain?
No.
Any lumps or bumps?
No.
Any skin changes?
No.
Any eye changes?
No.
What about your water work? Any blood in your water work or any changes?
No, there's no blood.
Okay. Any changes at all in your water work?
Yes, recently, doctor, I feel the amount is decreased.
Decreased amount.
Yes.
Okay. It's for the same period, 1 week.
Yes, doctor.
Okay. Do you drink water? How
Drink
many
what?
liters do you drink? Do you drink water? How many
As
liters?
usual, doctor. As usual, there's no any change as before.
Okay, but still the water work decreased.
Yes, doctor.
Okay. Any burning sensation in water?
No.
Okay. Any frothy urine?
No.
Any changes in your bowel work?
No.
If you have any past medical problem, I should be aware of, apart from your heart attack.
No, doctor.
You don't have a high blood pressure, high blood sugar, high
No,
lipids.
doctor. No. No.
Okay. Any surgical history apart from the last procedure for your heart attack?
No, doctor.
Any family history of smell problem?
Yes, doctor. My father had a heart attack when he was 50.
How is he doing now?
Yes, he is well.
Do you take any medications other than nitroglycerin?
Yes, doctor. I took aspirin, and also I took ramipril, and also I took bisoprolol and clopidogrel and atorvastatin and nitroglycine.
Okay. Do you have any
Spray
drug
as needed
allergy?
when I pain. No.
Okay. Sorry to ask you, do you take any illicit or recreational drugs?
No.
Over-the-counter medication?
No.
Any herbal remedies?
No.
Okay, I need to ask you some private questions, Mona, if you don't mind.
Yes, doctor.
When was your last period?
Uh, uh, doctor, I stopped the period. The period is stopped.
You told me that you are 45.
Yes.
Your mother stopped period at the same age?
Yes. Yes, doctor.
Okay. Do you have a partner?
Yes, doctor, I am married.
Okay. Do you have any kids?
Yes, doctor, I have 2 kids.
What is the age of the youngest one?
16 and 12.
Okay. Do you take any pills?
No, doctor.
Do you experience any hot flushes?
Yes, doctor, sometime.
I'm sorry to ask, do you have any problem with your intimate relationship? Like dryness
Yes,
of your
doctor.
private area?
It's sometime, doctor, yes.
Okay. Any history of abortions, miscarriages, I mean?
No.
Did you travel recently?
No.
Okay, Miss Mona. Do you smoke?
Yes, doctor, but after the heart attack, I stopped.
Okay, that's very good for you. Do you drink alcohol?
No.
Okay. What is your work, Miss Mona?
Housewife.
Okay. And how is your symptoms affecting you at home?
Yes, doctor, recently the symptom is affected to me so much. I
I'm
can't
so
do
sorry.
anything. I cannot do the normal activity, the usual
Okay,
activity.
sorry for that, Miss Mona. We're going to help you. Do you drive?
Drive? No, doctor.
Okay, can I examine you, Miss Mona?
Yes, doctor, please.
Okay, I'll start by examining general examination, looking at hands, any pallor.
There's no pallor.
Okay, any splinter, hemorrhage, any clubbing.
No, there's no any splinter hemorrhage. There's no clubbing.
What about the pulse?
The pulse is 56.
56, bradycardia.
Yes.
Okay, and what about blood pressure?
100 over 16.
Okay. I'll ask you to measure blood pressure lying and standing. Is there any change?
Yes, there's a change.
What is the difference between both systolic?
Yes, more than 20 systolic and more than 20 and more than 10 diastolic. The butcher hypotension. The butcheral hypotension.
Okay. Okay, I'll check the heart. Any scars?
Scars? There's no scars.
Okay, should it be CI? Only at the wrist scar or thigh scar?
Yes, there's wrist scar.
Okay, there's wrist scar. Okay. I'll do auscultation for the heart. Any
Normal.
abnormal sounds? Normal.
Normal.
GVB,
Not raised.
carotid.
Normal.
Okay, I'll check the face for any cyanosis. Any cyanosis, mouse?
There's no any cyanosis.
Pallor.
There's no pallor.
Okay, I'll check the eyes.
For what eye?
If there is any problem, if there is any pallor, if there is any dropping of eyelids.
No, negative.
Okay, I'll check the lower limbs. Any edema?
No, there's no edema.
Okay, and I want to check the chest rapidly. Any abnormal sound?
Chest? Abnormal sound where's?
In the lower chest, back.
You mean basal? No.
Yes, basal.
No.
Nothing in the chest.
Yes.
2 minutes left.
Okay, Miss Mona, may I know what is your concern?
Yes, doctor, I want to know I have another heart attack.
From what you told me and after I examined you, it's unlikely that you have another heart attack, but you have a complication from the medication that you are taking. It's called postural hypotension. This means that these medications make your blood pressure inside your blood channels drop when you change your position from a lying to a standing position. Do you have any other concern?
Yes, doctor, you mean you wanted to, that's the side effect of medication? You want me to stop this medication?
I can't stop this medication, Miss Mona, but I am going to involve our consultant to change this medication to another.
Yes, doctor. Doctor, you won't admit me?
It's better to admit you to run some blood tests and to check if you need any modification and justification of your medication.
Yes, doctor.
Okay. Do you have any other concern?
No, doctor.
Okay, Ms. Mona. Thank you for talking to me today.
Okay, 30 seconds remains. If you want to do another test, examination, take history, ask specific question.
I'm just going to run some blood tests tracing your heart to exclude any heart problem, and then we will proceed.
Okay,
When I confirm the diagnosis, we will change your medication to another.
from the history, you want to ask any question? Satisfied, right? Okay, time is up. Let's start the examiner question. Dr. Rasha, you can start, please.
Yes. What's your, can you present your case?
She's a 45 female, presented with visceral hypotension. After she started nitroglycerin medication, she undergone BCI 5 weeks ago for ischemic heart disease.
Yes. Which the medication can cause this?
Nitroglycerin is the most probably because it's vasodilator. It's called visceral hypotension.
Okay. What are your differential diagnoses?
Other causes could be, in this patient, most probably she has a cardiac problem, but when I listen to the heart, there is no murmurs. So I excluded that she has aortic stenosis, for example, she doesn't have any murmurs. And for she's eating well.
But the patient, there's no any murmur.
When I auscultate the heart, you said there is no murmur, there is nothing.
Yes. Why you put aortic stenosis?
Because it's one of the causes that cause dizziness and blackouts.
Okay. The other differential diagnosis?
The other differential diagnosis reflects, but she denied anything. She has attack only when she stands from a lying position. She's eating well, so she doesn't have any pallor. There's no anemia. She's not losing. She doesn't have any bowel problem, no diarrhea, no throwing up. There's nothing that explains visceral hypotension like losses, like body losses. And there is, she didn't say that this attack happened when she do exercise or something. So I excluded other differential.
Yes. How can, what investigation you want to do?
First, for the bradycardia, I need to do ECG and echo. And I will do basic blood test, complete blood count, maybe there is anemia. And I'll do electrolytes, maybe she has hypokalemia. And I'll do renal function test, liver function test as a basic. And then I'll do tilt table test, but she's not having this type of reflex. Tilt table test will be diagnostic for reflex type of hypotension, but she doesn't have this.
She doesn't have what?
Reflex chemical.
Okay, this patient need admission or not?
With this bradycardia and visceral hypotension, yes, it's better to be admitted, and heart tracing should be done and echo.
Yes. Okay, why does the patient have oliguria?
Polyuria, it's one of the maybe she has a renal affection.
Yes. What related renal affection regarding this patient, regarding this case?
Maybe she got glomerulonephritis.
But the patient, there's no any hematuria.
Yes, there is nothing.
Mm-hmm. Time up.
Okay.
Head time up.
Seven seconds. 6, 4, 3, 2, 1. Okay. The management. Did she mention the management plan?
No. I forget to ask about
Yeah,
the management.
briefly, Dr. Rasha. Just we'll
Yes.
listen to her management plan. What she will do.
Yes, doctor, please can tell me how to manage this patient?
I refer her to the cardiologist to change her medication to another because she had a side effect from nitroglycerin.
Mm-hmm. And
I don't know, we will evaluate her heart for the bradycardia, for the visceral hypotension, and for the oliguria.
yes, okay.
Any specific medication you want to give?
Midodrine for autonomic neuropathy.
Okay. Any specific education
Advices and
advices? Yes, exactly.
Okay. For that patient,
Mhm.
I think she should rest. Vigorous exercise not
Okay.
allowed.
Something is important related to the case. What do you think? Plenty of water.
Regarding her heart or her urine problem or her
Plenty of
regarding
water.
to background of patient recently MI.
Okay, she's in my. I asked it about driving.
Mm-hmm.
She
Hydration?
needs to follow in the outpatient clinic.
Hydration? Plenty of water.
Plenty of
Okay.
water. Okay.
Yeah, good hydration. Okay, almost time is up and exceeded 2 minutes. Let's hear Dr. Rasha comment, then I will comment. Well done, Dr.
Yes.
Azza. Okay, thank you.
Yes, Dr. Azza, you did well, but I have some comment regarding this patient. The first of all, this patient, background of this patient recently myocardial infarction. You need to take the history related to the background. The first of all, you need to ask about the detail about the recently MI, to detail about what happened, what investigation you do, if the patient is follow up outpatient clinic, cardiology clinic, if the patient do pulmonary اللي هو rehabilitation program, diet, smoking, alcohol, driving, illicit medication, ask about the medication that is important regarding this patient. Other thing, this patient recently MI, you should exclude the complication of MI. The patient now presented of fatigue. You did well ask about the palpitation to rule out arrhythmia, ask about the chest pain to rule out recently other MI, ask about the shortness of a breath and cough, but ask the shortness of the breath and cough late, ask about the leg swelling. It's good. Ask about the pallor. This is an important question to rule out the patient complex. Recently, MI said the one of the first differential diagnosis to rule out the patient other heart attack and to rule out other complication like bleeding, because the patient recently myocardial infarction. I think this is regard. The second, I think, ask about the numbness and headache and vision problem. I think there's not important. Ask about the CNS symptom. The other thing, if when the patient you said I have oliguria, maybe patient related to this case. Ask about be related to the heart attack. Patient develop acute kidney injury, which one of the cause of the patient lethargy, and also you need us to rule out other symptom of acute kidney injury, like the patient itchy, like the patient nausea, like the patient vomiting, like the patient fatigue. One of the symptom of acute kidney injury. Regarding most important. Regarding the other medication, drug history, you need ask the patient if there's any recently added any medication of any recently added any other medication. What the medication? Show me the medication list. There's any allergy from any medication, any recently changed the dose of medication, because this. The patient, the scenario, the patient 2 week, the patient changed the dose of ramipril from the 5 to the 10 milligram. The ramipril ACE inhibitor, you mean one of nitroglycine. The patient took the nitroglycine spray, and there's no relation between botular hypotension and nitroglycine. The most common side effect of the nitroglycine headache. There's not causing any botular hypotension. The other regarding to the clinic history, regarding the physical, examine the patient, the general look of the patient, and also examine the vital sign, examine the blood pressure sitting or standing. You feel the pulse, you feel the carotid and auscultation, the lung, the back of the lung, and the heart, to rule out the complication of MI. Regarding the clinical judgment, you not need to admit into the patient, because the patient due to the botular hypotension, due to change it into the dose of medication, just only you need to hold the ACE inhibitor and restart it again with the low dose. And the patient, there's no need to stay into the hospital. The concern you did well regarding this patient. There's no any suspicion of recently MI. Regarding the differential diagnosis, the patient, there's no any murmur. There's the patient you have dizzy when sitting or standing. They exclude aortic stenosis. And I think if this patient have aortic stenosis and recently MI, maybe do the patient valve replacement. The patient, there's no any symptom or sign of aortic stenosis. For that aortic stenosis, there's no one of the differential diagnosis regarding this case. This is the case, the differential diagnosis, botular hypotension related, recently changed the dose of ramipril. The second differential diagnosis may be the patient bradycardia and fatigue due to the patient took beta blocker, and also maybe patient related acute kidney injury causing the patient fatigue or lethargy, related to the patient dehydration and related to the ACE inhibitor, maybe cause acute kidney injury, and maybe related to the heart attack, maybe cause acute kidney injury. Okay, this is my comment.
Thank you, Dr. Rasha. Nice case and interested one, challenging one. I like the differential. Finally, it was like related to the medication. Not
Yes, I
Addison.
think
not
السيناريو I think
yeah.
I'm sorry I think scenario يعني aim this is scenario to evaluate the patient recently MI. You need to evaluate this the patient, advises this patient. You need to ask the patient about the regular follow-up. You need to ask the patient about how the diet, the smoking, the alcohol, the medication. You need to ask the patient if the patient go to the rehabilitation program. I think the important message regarding this the scenario to evaluate the patient, because the patient has has recently MI, and also the worry of the patient and concern of the patient regarding if you have recently MI, I think you need to ask about more detail regarding
Yes.
past MI.
Yeah, I think so, yes. So I will ask Dr. Azza now regarding MI. What do you think might be the cause of chest pain or sudden collapse in such patient after MI, 3 weeks or 2 weeks? Dr.
Dresser syndrome is the most common pericarditis after
Perfect.
MI.
This is one of the complication. What other complication?
Other complication of MI, MR, mitral regurg due to ischemic,
Perfect.
yeah,
Yes.
and heart failure.
Yes.
Other
Okay.
complications of MI, complications due to
Arrhythmia.
medications,
Yes.
and the procedure itself,
Yes.
as you commented, Dr.
Arrhythmia
Bassem,
also.
the comment,
Yeah.
yeah, contrast-induced nephropathy. Okay, and
Yes.
there is also I don't remember the name. It's called the cholesterol emboli, I think. After
I think it would be more acute, not later. But yeah, it's related to the contrast again.
okay,
Uh,
edematophilia
arrhythmia.
also.
Yeah,
Okay,
arrhythmia one of the causes or
arrhythmia.
of
Yeah.
definition. Yes, and restenosis of the stent, particularly if the patient non-compliant. And one more important and might be fatal. There is one complication, this syndrome.
Post BCI.
Yeah, well, not particularly as BCI, as MI.
Dressler syndrome.
Dressler already mentioned by Dr. Azza. This is pericarditis. But I mean rupture of the wall of the heart. Or I
Okay,
think
VCD. Yes, if it's not, yeah.
Papillary muscle.
VSD. Papillary muscle also
Yes,
mentioned
VSD.
already.
If not
Yeah,
rapidly treated.
yeah. Yes, you're right. Papillary muscle will lead to mitral regurg or tricuspid regurg, severe mitral regurg, or severe tricuspid regurg, according to the lesion. But what I mean the VSD, rupture of the wall or the septum of the heart.
Yes.
Yeah. Okay. So we cover most of
Yes,
the
I think is the most
yeah
complication of MI arrhythmia, so can early or
arrhythmia.
late, most common cause
Exactly.
of death. Mhm.
Yeah. Don't forget arrhythmia. Here also, Dr. Azza, you can put arrhythmia as a differential. This patient might have
Hmm.
arrhythmia, the cause of his syncope or fainting or lethargy.
Yes,
When you
I asked it about the heart racing. She denied.
perfect, yes, I know, yeah. She denies, but
Yeah.
there is bradycardia. So you can, you didn't even analyze the pulse. Patient is having bradycardia. Didn't say irregular, irregular. Is it hard to block? How much the rate? Yes, it was 56.
Okay.
But
Okay.
you have, yeah. And once you are doing ECG, you have to roll out complete heart block, one of the complication of MI, and it might lead to the fainting, right?
Yes, right.
But the good questions related to the system or relevant system here, you ask already the cardiovascular. You ask all the questions: chest pain, awareness for heartbeats, leg edema, waking at night, gasping for or looking for air. All these questions mean that the patient is failing or his heart is failing post MI. So it's important question to ask and to analyze the cardiovascular here. If there is awareness of heartbeat and you don't ask this question, you will miss the case. So it's very important to ask this question, particularly after chest pain or MI. As Dr. Rasha mentioned, the complication post MI, is it related to the contrast or related to the procedure or related to the MI? If the
Okay,
patient,
awareness of heartbeat apply for post arrhythmia for brady
yes,
and tachy.
yes, any awareness,
Yeah.
then you can ask if the awareness regular or irregular or fast or
Can
slow.
you tap for me? Yeah.
Exactly, yeah. So you have to analyze it more whenever she tell you, because usually when you are regularly heart beating, you will not feel the heartbeats, right? Never. You don't feel your heartbeat. But whenever you have extra beat or premature ventricular beat, you feel like there is extra. If you have or the patient is having AF, he will feel like I feel it's irregular. The same for slow. I feel my heart beats slow. So the awareness of heartbeat means there is arrhythmia, whatever the type of arrhythmia. Okay, but you have to ask and to analyze the relevant system here, and you did it. I like when you try to rule out Addison by skin pigmentation or skin changes. You are thinking about Addison, which is good. I also like when you ask about the baby or the kids to rule out, I guess, panhypopituitarism or Sheehan syndrome. Yeah, it might be earlier, but it's necessary to rule it out. You don't know, is it related to the MI or something else? Hormonal. The hormonal, also the endocrine, you ask already. The approach you did was great, but some question supposed to be in the order from up downward. It came dysregulated. So you ask about the CNS after I think the GI after the chest or the opposite, and you don't ask about the bowel work or the bowel habit with the
I
same
asked.
GI. Yeah, you ask. No. I mean, in the same time you analyze the abdomen. You ask. By the way, you ask most of the questions of every system. The GI, for example, you ask about difficult swallowing. Yeah, it's you can it can make sense if you ask about do you feel tasty or acid brush, right? For GERD or even the MI, patients sometimes will
Yeah.
feel acid brush. So it's this question makes sense rather than asking about difficult swallowing. Then, yeah, the bowel habit itself, I prefer to ask with the abdominal distension, abdominal discomfort. But you ask it later. Anyway, the GI, the genitourinary, sorry, you ask and you get the answer of decreased urine output or the water work, but you didn't ask more. Is it dark? When you notice it, whenever you have something positive, analyze it immediately. It might be the clue for the case. As Dr. Rasha mentioned, any medication, I believe, whenever you have medication listing, including 5 or more medications, the case might be one of the differential related to the drug induce. You didn't ask very important question, which can give you the case or the clue of the case. Do you change the dose? Did you add medication recently? She show you the list. You can ask for each medication or for the all medication the same question. Did you increase the dose? Did you add any medication? Are you compliant to the medication? These 3 questions will give you the clue if there is a change related to the current condition. In this case, as Dr. Rasha said, the ACE inhibitor was increased. So the ACE inhibitor increase will explain 2 things: the posture hypotension as diuresis, and it also explain the acute kidney injury, plus the CIN, which is contrast-induced nephropathy. So ask this question, it's very important about the medications. How are you compliant to the medication? Did you increase the dose? Any added medication? Okay. Apart from that, you covered the social well, you address the driving and the female history, everything. I think you did perfect. Dr. Rasha, I think, give us the case as the case for differential. It's not clear and straightforward for one differential. It's carry wide differential. So you can put any of these differential what we are mentioned. Okay. Any question, Dr. Raza?
Thank you,
Yes,
Professor.
yes, but regarding this case, the first differential diagnosis,
Okay.
البوتشر hypotension related to the ACE
Yeah.
inhibitor because the patient recently changed the ACE 2
Perfect.
weeks after he suffered
Yeah.
from بوتشر hypotension.
Perfect.
بس يعني take message in when review a lot of يعني الإكزام
Okay.
والسيناريو الدراج history mostly يكون في الهيدن agenda خاصة with recently added any medication with recently changed any medication يعني يا إما يكون ال first differential diagnosis or second differential diagnosis يعني a lot of scenario the same يعني the same idea ال hidden agenda في drug history.
Exactly, yes. Especially when you have medication list including 5 or more medications.
Yes.
So there is something hidden behind one of these medication. For example, peptic ulcer patient is having dizziness and he's pale. When you review the medication, there is aspirin or non-steroidal anti-inflammatory. You will have some clues in the medication or the
Yes, and
medication
also
list.
regarding this case, patient taken clopidogrel
Yeah.
and aspirin. Maybe patient have suffer from the bleeding. Bleeding, it was patient suffer from the botcher hypotension.
Yes, perfect. But
Mhm.
Dr. Azza already ruled out pallor or anemia when she
Yes,
asked about
yes,
pallor. She examined for pallor, but don't forget, Dr. Azza, leukonychia, koilonychia. It's important. You hold the hand already. Check for leukonychia in the finger or the nails. Just to rule out iron deficiency anemia. Although no anemia there, but you hold already the hand to rule out anemia. There is no pallor, yes. But if you have pallor, you must examine for leukonychia. Okay, or koilonychia as well. The last comment I want to add, yes, if let's imagine this patient is male. This question for Dr. Azza. In the same age, and he's coming with dizziness, fainting. What signify the symptoms, or what can you think about other cause related to his fainting? Male, 50s or 40s, post MI, taking nitroglycerin, and he came to you dizzy, feeling weak, lethargic. Dr. Azza, what question you can add, or what you can think about something related?
To a male, so a male gender.
Exactly, yeah. Particularly, he's a male, yes. What do you think? And it's common in practice, common in paces.
Common in cases.
I think someone wrote it. Perfect, yes.
Didn't see.
Yeah. Dr. Hatim wrote it. Male in this age, and he's post MI taking
Okay.
nitroglycerin. Yes, exactly.
I would never think
If you,
about it.
yeah, you have to think about it, and it's common practically. He's taking
I know
sildenafil.
he's talking
Yeah,
from
yeah.
pulmonary hypertension. I'm not sure.
No, no, no.
You mean that he didn't take the advices that he shouldn't take these medications after MI?
Sometimes even he received the advice, but still they are insisting to take this medicine.
Okay. Okay.
Okay, so you have to ask, particularly male gender, post MI taking nitroglycerin. Show me your medication list. If you didn't find this medicine, try to specify this medicine as a question. Did you take any medication for the intimacy? He will tell you, yes, doctor, I took it last night or the day before yesterday. After that, I feel dizzy, I feel sweaty, I feel whatever he will say, but it might be the case. Okay, so take care of this note. Any other question or comment, Dr. Azza, for this case?
Thank you, Dr. Kas.
Dr. Rasha, you want to add any comment
no,
before moving to the next case?
no, no.
Okay. Dr. Azza, did you find any case for Dr. Rasha?
Okay, fine. That's
Easy.
great.
Any case, even it was practiced before, it
It's
might
a
be
40,
new for Dr. Rasha.
okay,
Okay, good.
a
Write it.
40-year-old
Or-
female. She's presenting with polyuria.
Okay, this is the opposite. Male patient, Mr. John Adam. By the way, you are pronouncing the patient name wrong. You said Mona and I wrote Julia. Take care of reading the names.
Sorry.
No problem, but I mean in the exam, read the name or write it in your paper. With the stress, even you write the name, you will forget it. Okay? John Adam, 40 years, with complaint of or presented with polyuria. Dr. Rasha, I will give you 2 minutes, then we can
Yes,
start.
okay.
I will read the comment up. taking sildenafil. Exactly. Perfect, Dr. Hatem. AKI. Yeah, Dr. Aisha, what the cause of oliguria? The ACE itself, ACE inhibitor, post contrast. Sometimes with dehydration, the patient might have AKI, acute kidney injury. So he might have AKI, acute kidney injury, and the urine will be less. Okay. This is the first issue. The second issue, he might have the features of uremia. And this thing should be examined by doctor, as I supposed to say it, but I forget. The tremors, I mean fine tremors or flapping tremors for uremia. Even the signs of uremia in like encephalopathy, but he's conscious, so you can ask about the awareness, any loss of consciousness, as Dr. Azza already asked. Pericarditis as uremia also complication. These are the possible AKI presentation or uremia, I mean kidney injury. Other comments? Yeah, ruptures. Yes, thank you, Dr. Hatim. Yes, it was rupture. What is the syndrome? Dressler, you mean? Restenosis, arrhythmia, one of the differential, perfect. Beta blocker. Okay, Dr. Azza, I will ask you a question related to your differential. You mentioned aortic stenosis, okay?
Yeah.
But you didn't hear any murmur.
Yes, I didn't hear any memory. Yes.
Yeah, okay. What other differential you can put and you don't have murmur and it might be the same presentation of aortic stenosis?
Aortic sclerosis.
Perfect. And it will be in or at elderly patient, right? 60 plus.
Yes. Yes, and normal pulse pressure, no specific rupture.
Exactly. Yeah. You might have also no murmur. Perfect.
Yes.
But still, it might be the same
Yeah.
differential for aortic stenosis. Okay. Explanation for bradycardia. I think the patient was on beta blocker. That's why he's bradycardic or she's bradycardic. I don't remember the old medication list, but sometimes those patients, or not some, most of the time, they are on beta blocker. So you can say it's related to beta blocker. Or it would be arrhythmia or bradycardia post MI. So according to the case, I don't know in this scenario was on beta blocker, but I guess he was on beta blocker or she was on.
Yes, and beta blocker, yes.
Yeah, perfect. Multidisciplinary team, Dr. Azza, whenever you want to do management for any patient, start by multidisciplinary team. Of course, you will call the cardiologist, but you can call also other departments or specialty. You can call nephrologist, for example. You
Yes.
can call,
Yes.
right? Echo,
Yeah.
specialized nurse. So it's not only cardiologists. And don't stop medication by yourself. As you said, I might hold this medicine and I might refer you to your heart doctor to find a new medicine or to find the best interest of your condition. But you might hold, not stop. Don't stop medication may be necessary for the patient. Okay?
Mm.
Dr. Bassem, can I ask question?
Mm. Sure, sure.
Yeah, in this case, because the main complaint lethargy, so we will start to, because I don't feel Dr. Azza, she is like organized in her taking history. So we must start by general symptoms first, because the lethargy from the one of the general symptoms, or we must start by cardiovascular symptoms, or
Okay,
because
I will tell you.
I feel her she
Mm,
asking question from here and here.
No, no, I will tell you. Dr.
Yeah.
Azza did the best. Why?
Mhm.
Because she asked what you mean by lethargy.
Okay.
So the meaning of lethargy either to be weakness, so it would be related to something else, not rheumatological, for example, or
Mm-hmm.
it would be related to the cardiovascular, as in this patient having dizziness while
So
standing from sitting. So it
mhm.
might be cardiac, particularly this patient having recent MI. So you have to relate
Start by
this
cardiovascular. Mm.
exactly because most probably this patient is having something related to her MI, which
Okay.
already came as medication related, right?
Mhm.
It's not something else away from the cardiovascular. It's related to cardiovascular system. Yes, one of the differential AKI, which is nephrology or kidney, but you don't know. You started by dizziness
So
from
yeah, we
standing.
can start like by all the symptoms of
Yes,
cardiovascular. Then
yeah,
we
exactly.
go to general.
Yes,
Then the
yes,
past medical history. Then we will
perfect.
see the systemic review
Systemic review.
all
Perfect.
and
Yes,
yeah. Mm-hmm.
this is the
Okay.
way. Then family history, travel, HIV, and do you smoke? Do you drink alcohol? And
Because when
this.
we ask some
Are we,
question from here and here, maybe they will
no, no, no.
go-
It's not from here
yeah.
and there. If you start analyzing the relevant system,
Mm-hmm.
then analyze the constitutional symptoms, then you ask for the past medical history, and after that, systemic review. I think this
Yes.
is the best way, and this is my favorite approach.
Then the differential diagnosis from the
By
postural
the way,
hypotension, one by
you,
one, Addison and autonomic. She not ask about diabetes or something regarding the autonomic neuropathy. She asked about acute
okay,
loss. Yeah,
okay. What question related to diabetes, if you want to ask about it?
the hypoglycemia or something like this.
Okay, why you will ask about hypoglycemia if the patient deny that he is diabetic?
Yeah. First of all, I must ask her about if she have.
Exactly.
Yes, yeah.
You have to have diabetes
Yes, first. Yeah,
to,
I know.
exactly to analyze
Yeah.
it. So the patient is not diabetic even. So why I'll
And
ask
if
about?
we remember the cause of postural hypotension, it's Addison and autonomic neuropathy and acute loss, then hypertension medication. If we put it this four and asking one by one, maybe we can get the
Okay,
cause.
I agree with you for somehow, but it's clear that this patient having something related to the MI and the medication after the MI. It's clear it's related to MI because she is medically free. Let's imagine the opposite. This patient having hypertensive as best medical history plus diabetes. What do you think? You can add another differential?
Plus diabetes.
Yeah, the same patient having
Mm.
past medical history of diabetes and hypertension. What do you think? You
Yeah,
can
we
put
must
another differential? Yeah, tell me.
autonomic neuropathy.
Perfect. This is for
Yeah.
diabetes.
Yes.
Or what else regarding the diabetes? Hypoglycemia.
Hypoglycemia.
And for the hypertension, what you can put? Hypertensive
The
encephalopathy, for example. I am giving you examples, but not the
oh.
case. Okay,
Yeah.
hypertensive encephalopathy. If he or
Mhm.
she is not well controlled.
Mhm.
What else?
But only the medication cause
Medication can be.
postural hypotension. Only the
You are talking about postural
anti-hypertension
hypertension.
medication.
No, no, no.
Yeah,
I'm talking about dizziness in general.
yeah, dizziness. Oh no,
Yeah, postural hypertension. You can think about diuresis.
diuretic and ACE
Yeah,
inhibitor
diuretics
and
and ACE inhibitor, and
mhm,
also beta blocker.
beta blocker. Yes,
Perfect. And for
mm,
diabetes, autonomic neuropathy or hypoglycemia. That's it.
yes, right.
Yes. Okay.
Okay, thank you, thank
So
you,
when
Chris.
you have to ask. But if you don't have, why I should ask?
But if we put it, yeah, if we put it, she asked about
She asked
diabetes,
about she asked about
diabetes,
any past medical history.
but she
No, no,
not
no,
asked
no,
by.
no need to specify. If she has, she will tell you.
Mm-hmm. Okay.
It's not a must to ask, do you have high blood sugar or do you have high blood pressure? Some patients, they will have either the other one if you didn't ask, and she will tell you, no, I don't have. I mean, if you said, for example, if you ask about high blood pressure only, and you didn't ask about high blood sugar, she will tell you, yes, I have high blood pressure. Now you know she's hypertensive. You forget to ask about diabetes or high blood sugar. She will not tell you, yes, I have, doctor, wait, doctor, I have diabetes. If you ask general question, what's your past medical history I should be aware of? She should tell you, yes, I have diabetes and hypertension.
Okay. And
You got
I
it.
feel
So
also she not be too much like um, mm, what empathy and sympathy with the patients, right?
No, I think she
Yeah.
was fine.
Okay.
She was fine.
Yeah.
Dr. Kinana, you are kind examiner. What happened to you?
I don't know. Just I'm
Be, be,
trying.
be
Okay, thank
supportive.
you.
Be
Yeah.
supportive.
Yeah.
Okay.
Okay,
Okay.
thank
Thank you, Dr. Kinana. Let's start, Dr. Rasha. Ready?
Yes.
Yeah. Here you go.
Hello, my name is Dr. Al-Mahdi. I am doctor in medical ward today. Can I confirm I am talking to the Mr. John Adam, 40 years old?
Yes, Dr. Smith.
Okay, Mr. Jones, we are here to discuss about your health status and examine you and address your concern. That's okay with you?
Yes, doctor.
Okay, I received a letter from your GP status me that you have increased the amount of the urine. Can you tell me what do you mean by increase the amount of the urine?
Yes, doctor. 2 months ago, I started to notice that I pass more waterworks than usual.
Yes, you mean increase the frequency to go to the bathroom or increase the amount of the amount of the waterwork?
Both of them, doctor.
Both of them. Since 2 months.
Yes.
It was sudden or gradually?
It started gradually, but it's increasing.
Is increasing. Is it the first time or you have previous attack?
Not first time.
Okay. Can you tell me how many liter do you pass?
About 3.
3 liter. Can you tell me, are you awake from the sleep to go to the bathroom?
Sometimes, yes.
Okay. Can you tell me, are you compensated? The water is lost. You mean how many water are you drink? How many
Yes,
liter?
I drink about 2 liters.
2 liters. Okay. Do you have any problem into the water work, like increase into the like frothy urine,
No,
like passes of gravels?
no,
There's any blood,
no, I didn't notice anything.
any burning sensation,
No.
any thirsty?
Yes, I feel thirst.
I feel thirsty. Okay. Since how long?
The same period, I think 2 months.
The same period. Okay. Do you notice any recently any high body temperature?
No,
Sorry, do you have any history of flank pain?
history of what?
Flank pain.
No,
Okay. Any passes, any gravels?
no,
Okay. Any history of high body temperature?
no, doctor, I don't have.
Okay. What about your weight?
I think it's the same, no much change.
What about your appetite?
It's fine.
Any lump or bump to the anywhere?
I didn't notice, no.
Okay. Any neck swelling?
No,
Any weather preference?
no.
Any any mood change?
Yes, doctor, I have a problem and I'm following with my psychiatrist.
Since how long?
I started treatment 3 months ago.
What the medication you start?
Lithium.
Lithium. Okay. Are you still complying with this medication?
Yes, I take it as prescribed.
Any recently changed it or added any medication or changed the
No,
dose? Okay.
no.
Any history of tiredness?
Not too much. It's only feeling low mood.
Low mood. Any recently illness?
No.
Any joint pain?
Sometimes I have joint pain.
Where exactly? Where the site of the joint pain?
My knees.
Both knees?
Yes.
Okay. Any history of back pain?
No.
Any skin rash?
Yes, I have this skin rash on my nose.
In your nose. Can I have a look?
Yes.
Okay. Where's the site of the rash?
Over the nose.
Nose. Just only over the nose. There's no any other site?
Yes, there is a skin rash in the legs also, shins.
In the legs. Since how long?
I think I have it for 4 months now.
4 months. Okay. Did you seek any medical advice?
No,
Okay. Any back pain?
no,
Anyone coming to better than before?
no,
Any bleeding from any orifice?
no, doctor.
Uh-huh. Any history of chest pain?
No,
Awareness of the heartbeat?
no,
Any shortness of breath?
no.
Any cough?
Yes, I have cough.
Since how long?
4 months.
4 months. Okay. It was dry or phlegm?
It's a dry cough.
Dry. Any nosy chest?
No,
Okay. Any tummy pain?
sometimes yes, I have tummy pain.
Okay. Any acid brush?
No,
Any heartburn?
no,
Okay. Any change into the bowel habit?
yes, I have hard motion.
Hard motion. Okay. Any blood passes from the back passage?
No,
Any bleeding from any orifice?
no,
Okay. Any headache?
yes, I have headache.
Okay. Any loss of the awareness?
No,
Okay. Any shaking of your hand?
no,
Okay. Any throwing up or feel sick?
no.
Okay. Any medical history I should aware of?
Only my bipolar disorder and I am taking this lithium.
Did you check the blood sugar?
Yes, it's fine.
It's fine. Okay. Any recently, any history of yellow of your eyes?
No, doctor, nothing.
Okay. Any recently admission to the hospital?
No,
Any radiation? Any exposure to the radiation?
nothing. No,
Any surgery?
no,
Apart from the lithium, are you taking any other medication?
no, doctor, I don't take.
Okay. You said the lithium, there's no any recently change in the dose of medication.
Started only 3 months ago.
Okay. Any family history of the same illness?
Nothing I'm aware of.
Any disease runs in your family?
No, doctor, I don't know.
Any history of cancer?
No,
Okay. Sorry for asking this question. Any problem to the intimate relation? Are you married?
yes, I'm married.
Okay. Are you have any extramarital relationship?
No, doctor, I don't.
Okay, male. Sorry. Okay. Okay. Drug history. Okay. Do you smoke?
Sometimes, yes.
How many cigarettes per day?
Only 1 or 2 of them.
Okay. Did you drink alcohol?
It's occasionally only.
Okay. How much these the symptom affecting to the job and daily activity?
Okay, I feel it's very embarrassing going to the bathroom every year.
What's your job?
I am a secretary.
Okay. Can I examine you?
Yes, doctor, go ahead.
I want to examine the general look of the patient. And also I want to examine the general examine to the hand if there's any clubbing, if there's any chylonychia. I want to examine the vital sign, the pulse. I want to examine the eye for pallor and jaundice. I want to examine the mouth. I want to examine the lymph node. I want to examine the thyroid. I want to auscultate into the chest. And also I want to examine the abdomen and also I want to see the rash.
Okay, the rash in the nose, it's lobus pernio, and in the chins, it's erythema nodosum.
Yes. Okay, I want to auscultate the heart.
Okay, nothing in the heart.
And also I want to see the joint pain. If there's any deformity, if there's any swelling, if there's any hotness and sign of arthritis. In knee
No,
pain,
no.
in knee joint. Okay. Okay, what's your concern?
What is going on with me, doctor? Do I have any problem?
Yes, Mr. Adam, regarding to your symptom that you have, and after I examine you, you most probably you have a condition is the called sarcoidosis, is the medical term for the medical condition. Due to the disease unknown origin may be related to the disturbance on the defense system, which attack multiple system in the body, like skin, like joint, like lung, and also leading to an increase the calcium in the blood, leading to the symptom that you have like increase the amount of the water work and joint pain and skin rash. What we need to do now, need to do some blood test and imaging. Sometimes we needed taken to the SNP to confirm our diagnosis. And after that, I will refer you to the group specialist, include the lung doctor and the skin doctor and joint doctor, to provide to the proper management plan. The second is most probably this the disease is self-limited disease, but sometimes needed to start some medication. When confirmed diagnosis, I will arrange another meeting to discuss about these treatment. The second differential diagnosis may be related to medication. Are you taken for the mood change, maybe also causing raised the calcium and also raised the increase into the water work. For that, we discuss with the psychiatric doctor regarding this issue. Do you have any other concern?
Is it curable, doctor?
Your concern is valid regarding the sarcoidosis as self-limited disease, is curable disease. Sometimes is not needed to the treatment, but sometimes some case needed to the start of the treatment, which they call the steroid. For that, needed to refer to the group specialist to discuss if you need to start this medication or not. Do you have any other concern?
Are you talking about my lithium medication, doctor, or?
I talk about the sarcoidosis.
Okay.
Regarding the lithium, the second of differential diagnosis, because the medication may be causing, which are taken for the mood change, may be also responsible for increase the amount of the water work. For that, we'll refer to the mood doctor to discuss with you regarding this issue.
2 minutes left.
Okay. Do you have any other concern?
No, doctor.
Hello?
Thank you.
Okay. Can I ask you some questions, please?
Yes, go.
Do you have any redness of your eye?
No.
Okay. Any pain in your eye?
No.
Okay. Do you have any other concern?
No, doctor. Thank you.
Okay.
Okay, still 1 minute, 30 seconds. You want to examine the chest, or you mentioned the chest?
Yeah,
Examination?
Yes,
didn't
examine the chest and the lymph node.
Okay,
Yes,
what you are
examine
looking
it.
for in the chest?
I'm looking if there's any apical fibrosis.
So, yeah, looking for crackles, yeah, right?
Mhm.
Yeah. And if you have crackles, what you'll do?
If you have a crackle, ask the patient to cough.
Perfect. What do you think? It will disappear?
There's no change because fibrosis.
Exactly. Okay, thank you, Dr. Rasha. Let's go to the examiner questions. Dr. Azza, you can start now.
Okay, what is your finding in that patient?
My patient is Mr. Adam, 40 years old, presented with history of polyuria. increase the amount of the water work associated with associated with the skin rash and joint pain, skin rash into the face and the leg, and also association with the symptom of hypercalcemia, like the constipation and constipation and heartburn, I think. And also the second, the patient presented with the mood change, which is taken mood lithium, mood stabilizer drug.
Do you have any other differentiate for that patient?
Other differential diagnosis may be malignancy, but against that, the patient, there's no any history of lump or bump, or there's no any change into the weight.
Other differentiate?
Other, yes, my patient is diabetes insipidus related to the underlying the cause sarcoidosis. The second differential lithium-induced hypercalcemia and polyuria. The third differential diagnosis may be malignancy caused hyperkalemia, but the patient against there's no any weight change, there's no any lump or bump, there's no any history of any history suspicion malignancy.
Do you think that hypercalcemia is only related to malignancy?
Is rated what?
Is only related to malignancy? Do you think hypercalcemia is only related to malignancy?
Yes, maybe malignancy caused hypercalcemia.
In that patient?
Yes, hypercalcemia related to sarcoidosis.
Okay, I understand that hypercalcemia related to sarcoidosis. What other causes of hypercalcemia in that patient?
Other cause, lithium.
No. Okay. Do you think that he has a complicated condition like parathyroid problem?
Parathyroid problem. Yes, but
Yes.
parathyroid not causing any joint pain, not cause any skin rash. There's not causing any lupus perennial. There's not any erythema nodosum. Parathyroid just only cause hypercalcemia, but there's no other symptom not related to the hyperparathyroidism.
Okay. How sarcoidosis causing polydipsia?
Sarcoidosis causing polydipsia. I don't know. Maybe related to the hypercalcemia. I don't know.
Yes, and the other?
Polydipsia or polyuria, you mean?
No problem. Polydipsia, diabetes insipidus, okay.
Yes, you mean sarcoidosis, how sarcoidosis causing polyuria, not polydipsia.
Okay.
Yes, sarcoidosis caused polyuria related to hypercalcemia, and also sarcoidosis may be caused polyuria related diabetes insipidus.
It's craniogenic diabetes.
Yes.
It was craniogenic and nephrogenic.
Yes.
Okay.
Yes.
Okay, how are you going to manage this patient?
Apart from manage this patient, apart from the basic investigation, CBC, LFT, inflammatory marker, I want to do serum calcium, bone profile, serum calcium, vitamin D, magnesium, parathyroid hormone. I want to do ACE inhibitor. I want to do chest X-ray, pulmonary function test, high resolution CT, transbronchial biopsy, ECG, and also I want to do renal function test. I want to do MRI brain. Regarding the treatment, this patient, the most of the case, the patient self-limited disease, but regarding this, the patient presented with hypercalcemia itself needed to start the treatment steroid.
Okay, thank you.
Welcome.
Finish. Still 20 seconds. Anyone want to ask or any question? Dr. Azza remains.
No,
I will ask
I
here.
didn't prepare any cases, so I just.
Okay, last question. What do you
Okay.
think, Dr. Rasha? Do you think there is other possibility for other differential of
Regarding this
polyuria? Yeah,
yes,
polyuria
regarding
without
polyuria,
hypercalcemia. Yeah, tell me.
regarding polyuria itself, there's a lot of differential diagnosis. But regarding this case, the polyuria is related to hypercalcemia. You
Yeah,
mean
this case. No,
uh,
in general, and
Okay, he's
patient is having.
bipolar. It's psychogenic
Yes.
polydysphagia. That's why I'm
Yeah.
trying to tell you in this patient.
Oh my
It's
God,
the first
Doctor.
differential. It's first
psychogenic, but
differential in the psychogenic.
yeah,
He's
Yes,
drinking
patient is
too much and
psychiatrist.
passing urine too
Exactly.
much.
Yeah.
was the
Yeah, this is
patient's
the
right?
first differential.
Psychogenic when the patient drink a lot of water.
Yes, he's
Yes,
having psychogenic or psychic issue background. He might be.
even if he told you he doesn't drink too much, but he's drinking, you understand? Because he's bipolar. It's
I
first
think,
differential. I get the case. It's forward the case. I get it from one book. Okay, I didn't invent it. Okay, it's first
Okay.
differential.
no, no,
Psychogenic.
Okay.
but
Okay.
listen,
Related
you say
sarcoidosis.
you drink not to drink not to drink large amount of the water for that. Mhm.
Okay, but
Yes,
his insighted patient, yes, you should put it in the first differential. That's what is
yes,
written here.
but the psychogenic is not the first differential diagnosis. One of the last differential diagnosis,
Okay,
because
it's
the
one
patient
of the
have other
differential,
symptom of
but it's one of the
hypercalcemia.
differential. Yeah, it's okay. I agree. Somehow it could be the case, or could be a differential. But let's hear Dr. Azza comments about the case. Then
But
I
I
will
think
comment.
psychogenic after excluded the other cause and after the
I
patient is drink a lot of amount of the water
Yes, yes,
more
yes. I
than
agree,
the
Dr. Ash.
cost of
By
the
the way,
water.
I
Mm.
agree. There is signs and symptoms of hypercalcemia, and you should put the sarcoidosis on the top. I agree with you.
Yes, I try
Yeah,
to make it
but
forward the case, yes.
yeah, but still, I can think about the psychogenic polydipsia. Why? Because he's psychogenic patient or a psychiatrist patient. He might take this water extra. Anyway, let's hear Dr. Azza comment. Then I will comment. Go ahead, Dr. Azza, please.
I don't have comments, Dr. Basim. I told you I didn't prepare any cases, so I just pick it from
Okay.
my book. Okay.
Okay. My question to you: what the case is? It one diagnosis or case for differential?
It's a differential, but I added this about sarcoidosis to make it more, it's not only related to lithium
Okay.
or psychogenic. So
Yeah.
I added, yeah.
Yeah. I agree. Usually they brought it either lithium as the nephrogenic diabetes insipidus,
Yes.
or sarcoidosis as hypercalcemia, or sarcoidosis as cranial diabetes insipidus, or psychogenic polydipsia, but not bringing all together. You brought
It's not
all
all. I'm
differential.
trying to, no, it's not all. It's only two, lithium and
Okay.
sarcoidosis. I would.
Okay, but you want her to say as a differential by psychogenic polydipsia, but it's not in the case,
Okay.
right? Because 2 liters per day is not a cause of psychogenic
Yes,
polydipsia. Yes, I
yes,
agree with Dr. Rush.
yes, I mean 2 liter
Yeah, we
is
can
not
drink 2 liters.
psychogenic polydipsia.
Yeah, yeah.
Yes,
I think
you can drink 2 liter, yes.
psychogenic polydipsia, he's drinking, I think, more than 4 liters. I am not sure about the amount. Someone can search about it. But he drink a lot, not 2 liters. 2 liters
Yes,
is the
yes,
usual intake for us. But anyway, Dr. Rasha, you can think about it once you ask about this question. If the examiner asks you what else, you can mention psychogenic polydipsia. And by the way, he will ask you how to differentiate between psychogenic polydipsia and the diabetes insipidus. What the test, Dr. Rasha? How?
psychogenic polydipsia and diabetes insipidus.
Yeah.
Yes, water deprivation test.
Yeah, perfect. So you have to know how to differentiate and you have to put it in your differential, right?
Yes.
Okay, this is regarding the differential. I will comment.
Dr. Basim,
Sorry, Dr. Ansa. Yes.
I think from the history you can differentiate also by asking the patient if the polyuria wake him from the sleep. Because in
Yes.
psychogenic polydipsia, the patient will not wake from the sleep to pass urine.
Yes, ask the patient regard awake from the sleep and
Yeah,
patient
she
said
asked this
yes.
question.
Mm.
Perfect.
So you can put it in the differential in the list
Yeah.
last one and said again is that the patient does not
Yes.
awaken from the sleep
Perfect.
to pass
Perfect,
urine.
Doctor. Yeah, thank you, Dr. Maisun. You're right. I think, Doctor, Azza want to give us the differential of polyuria and bases. So it's not specific in this case to say this or that, but she want to say you have to think about all these causes, as I mentioned already. Okay. Diabetes, by the way, diabetes mellitus could be one of the differential patient taking a lot of water or polydipsia and he's passing a lot of water. But what can differentiate between hypercalcemia, polyuria, and hyperglycemia, polyuria? What question you can differentiate between diabetes, polyuria, and hypercalcemia, polydipsia? Anyone? Anyone can answer? No, not complication. No complication, Dr. Hatton. Now you have patient with polydipsia and polyuria recently started. What question can differentiate between polydipsia and polyuria due to hypercalcemia and polydipsia, polyuria because of hyperglycemia, which is diabetes?
Maybe busing levels and hyperglycemia.
Okay, this is one. It's by the way, it's not only one difference. It's you can have a lot of difference.
Hypercalcemia,
So
there is
that
tummy pain, there is constipation, there is headaches,
exactly,
there is
yes, exactly,
confusion.
yes. So so you can ask it about the hypercalcemia signs and symptoms and the diabetes signs and symptoms. But what in the urine questions you can specify for the hyperglycemia urinary system?
Maybe frothy urine if it's complicated diabetes.
Perfect. Yes, perfect. This is the one. Yes, perfect. So the diabetic patient will have frothy urine, but hypercalcemic patients, I think, less likely to have frothy urine because no proteinuria, unless the kidney is impaired. But hypercalcemia itself will not cause for frothy urine. Frothy urine because of protein, right? And protein will be leaked because of what? Because of diabetic nephropathy. Otherwise, you can ask about the symptoms and signs of hypercalcemia: low mood and headache, and also you can have flank pain, renal colic, abdominal pain, constipation. All these symptoms would be associated with hypercalcemia, and it will not be associated with the hyperglycemia. Clear?
Also, Dr. Basim, we must here check the level of lithium,
Yeah, this
the
is one of the
important.
investigation. You mean? Yes,
Yes,
investigation. Yes,
yes,
perfect.
the
But
importance.
okay, what test you can do to rule out lithium toxicity in examination, and Dr. Rasha should do? Who knows?
Lithium toxicity,
Yes, Dr.
tremor,
Rasha.
tremor,
What you should
tremor,
do? Perfect. What kind of
tremor.
tumor? Yeah, for the acute, and what kind of tumor for the chronic?
Fine
Course,
and close.
course and course remedy.
Yeah.
Perfect. Yeah. For the chronic, C for C, chronic course. For the acute, fine tremors. This is the way how
Also
to.
check the dehydration symptoms or
Yes, she
in
should
the
ask.
yes.
Yeah, she should ask. She should ask and to do examination of the dehydration or the hydration state.
Yes, ask about diarrhea, throwing up, and feel sick.
No, the examination. Dry mouth, dry mucous membrane.
Yes, yes.
Yes.
Fluid
Okay.
status. Yes.
Yeah, volume
Yes.
status. Perfect. Yes. And postural hypotension. Whenever you have polyuria, gastroenteritis, loss of water, whenever or wherever the source, you have to check for the volume status and the postural hypotension. Okay. Next, yes, I want to comment, Dr. Rasha. There is some questions. I think it's not. It will be just consuming the time. Bleeding from anywhere. I think it's not in this case important to ask about bleeding because there is no bleeding or there is no signs or symptoms of pallor. And by the way, you repeated this question twice. So try to not to ask the question which is not related, or
Yes, ask about
you ask.
ask about the pallor and bleeding to rule out multiple myeloma and to rule out any cancer. For that, ask about pallor and
Okay,
bleeding.
okay, yeah, okay, good. Multiple
Yes, I
myeloma,
think
yes,
very important.
hypercalcemia,
Very
yeah.
important. Rule the
But
cancer and the multiple
anemia,
myeloma.
yes, but bleeding. Okay, if you are suspected anemia due to bleeding, okay, okay, now I got it. Okay, yeah, for
Also,
multiple
Dr.
myeloma.
Bassem, the
Yeah.
Yes,
explanation of
any tumor, yes, like colorectal may be caused bleeding and also cause hypercalcemia. Any tumor may be caused, GIT tumor may be caused bleeding.
Okay.
Mm.
Okay, thank you, Dr. Rasha. The examination steps I want, and I prefer you to do it in details, because in the exam you will not ask, and the examiner will tell you the finding. No, I want to do it step by step. I want to examine the hand for pallor until here. Do you have pallor? No. I want to examine for chorionicchia. She has no. The pulse. Don't mention the whole tests or examination steps, and wait for the results, or the surrogate tell you yes she has or she doesn't have. Why? Because what you are doing now you will do in the exam. If you finish the all examination step quickly, you will in the exam also you will finish the examination steps quickly. So take your time to express every step in the examination. I want to check for blood pressure sitting and standing. Offer it. Doctor, I need to examine for blood pressure sitting and standing. Then take time to check for the next. The eye. I want to examine the eye for redness, for dryness. I want to examine the mouth for dryness and for ulcers, for example. Okay, the chest. Do the all steps of examination in the chest. Why? Because the sarcoidosis will lead to fibrosis. Fibrosis, you will have less expansion. You will have, for example, crackles, as you said. The percussion, you have to do it, although it will not be impressive unless you have consolidation. For example, you might have high percussion notes or dullness. What I mean, Dr. Rasha, try to train the all
Yes,
steps of examination. Okay, okay.
yes,
Otherwise, you did perfect. You got the case. You got good differential. Yeah, for the concern also. Answer the concern according to the question. What I have, doctor, you have sarcoidosis. Explain the sarcoidosis. What other concern? What other possibility? Tell her the other possibility. Don't be volunteer to give her the other differential. You might have another condition related to the lithium. No, tell her the concern according to the question. What I have, you might have a condition called sarcoidosis. Okay, this condition as you explain it exactly. Then the next thing, wait for her other concern. Do you have other concern? Yeah, doctor. Is it curable? Yes or no? According, but I think in the sarcoidosis, it's not curable. It's controllable, and as you said, self-limiting. But in certain indication, you might start medication called steroid, right? This is the way to address the concerns. Why? Because the surrogate or the patient will give you 3 or 4 concerns. Give him chance to express and to ask you the other concern, even if you have good time. Here you have good time because you did the whole examination steps. I think Dr. Azza also she didn't give you the positive finding one by one. She just tell you at the end the positive finding, but supposed to ask you every step what you want to examine here. Then you will answer here. I want to examine for anemia, for example, for pallor. Then the next system, what you want to examine the chest, I want to examine for like that. In the heart, I want to examine for murmur. Okay, that's why you finish early, but you're fast. The question, the fluency of the question, yes, you finish all the questions related to the case and related to differential diagnosis. You know how to analyze the polyuria, Dr. Rasha, which is perfect. If you have any case of polyuria in exam, you will do it. You have any question?
inshallah.
Yeah,
Thank you.
hopefully, inshallah. You have any
Thank you.
question? Most welcome. Dr.
Dr.
Azza,
Bassem, the
yes.
explanation of sarcoidosis, it's a defect in defense system. or it's a multi-soreness or a cluster small cells accumulate in different organ.
Okay, when you have a biopsy, what you will find in the biopsy? If you
It's
do,
granuloma.
yeah, granuloma, what's called?
Non-caseating
Non-caseous.
Yes, perfect.
So
So
when you explain the disease for patients,
yes, what do you
we
think
will,
this nature of the disease, the nature of this disease?
yeah, it's a defense in
Inflammation. I guess it's
it's,
inflammation.
yes, yeah. So it's not a defect in defense
No,
system.
no,
It's a
no, no, no.
multi-soreness disease. Yeah,
Yeah. I believe it's one of
because
the
she when
inflammatory.
explain the disease, yeah,
Yeah,
she
she
said
said
it's
yes.
yeah
But
defect.
I think sarcoidosis, there's a known cause.
Yeah, for
Unknown
a
or
non-cough.
inflammation. Yeah, but it's not defense system issue. Okay, it's not autoimmune disease, Dr. Rasha. Why? Because you don't have antibody in this
Mm.
disease. You don't have antibody, right? It's inflammation, non-caseating granuloma. So
Yes,
soreness
but there's no any cause to know how to granuloma is يعني unknown cause.
happened.
Why this
Yeah.
granuloma?
Okay,
Yes,
it's
we don't.
unknown. It's unknown, but it's not autoimmune. Okay, mention
Mm.
unknown, but don't mention autoimmune.
Yes, it
If
is
you,
of unknown etiology, but it is not
yeah,
autoimmune.
yeah, it's not autoimmune. Yes, exactly. And you can say it lead to soreness in multiple areas, as you said, the lung, the kidney, the lungs and the face, the brain. Okay, I mean for
Yes,
the
okay.
neurosarcoidosis. Yeah. Any other questions?
Dr. Basim, can you explain the approach for polyuria
Yeah, sure.
with the analysis?
Okay,
Just
the analysis, as Dr. Rasha did, as analysis of urine polyuria. What you mean is it increasing the amount or in the
yes.
frequency? And it's important to know the other symptoms related to the urinary symptoms. I mean, dysuria, passing gravels, and flank pain, stones, all these questions related to the urinary symptoms or urinary system.
Uh-huh.
Passing blood, it's
Uh-huh.
important also. Frothiness, all this as a relevant system analysis. Dr.
Mm,
Rasha
mm.
did this in perfect way. So you will start the polyuria analysis, onset course duration. Finished? I think here you cannot say what increase and what decrease unless the patient is taking a lot of water. So you will start analysis onset course duration. Is it the first time or it was happened before previous attack? No, first time. Now you'll ask about how you are compensating for this polyuria. I'm drinking a lot. I'm not drinking. I am drinking good. Why? Because if he's passing a lot of urine without compensation, he will be dehydrating. If he's exceeding the amount what he's passing, so he will be psychogenic polydipsia. He's drinking more water than he's passing. Okay, the next, as I said, the relevant system analysis, which are dysuria, frothiness, gravels, stones, blood in urine, flank pain, all this question related to the urinary system analysis. Then you can ask about the constitutional symptoms, loss of weight, loss of appetite. What do you think the importance of loss of weight and loss of appetite in this condition,
Yes,
the polyuria?
yes, malignancy.
What? Perfect. And multiple
Yes,
myeloma, one of the differential,
yes,
yeah, is
hypervitamin
also,
due to
yeah,
yes, multiple myeloma, hypercalcemia. Mm.
exactly. And also it's cancer. Multiple myeloma is one of the cancer. So you might have
Yes,
also loss
yes,
of weight.
yes,
Okay,
loss of weight.
night sweats, of course,
Mm.
night sweats, and the body temperature, the high body temperature. This also for constitutional symptoms. If you have positive constitutional symptoms, you will think about cancer, and you can put cancer itself can lead to hypercancer, any cancer, metastasis, cancer, multiple myeloma, myeloproliferative, or any hematological cancer might lead to hypercalcemia. Let's go to the
Mm.
next. After finishing this, he will ask about past medical history. What the importance of past medical history related to the polyuria? What do you think? Past medical history. What you have long-standing disease I should be aware of. What do you think might be the answer?
Diabetes?
Yes. If he said yes, I have diabetes, this is one of the differential.
Mm.
You have to put it definitely. It's one of the differential. If you said diabetic as a polyuria, the examiner will not argue with you. Yes, polyuria is one of the manifestation of diabetes, right? So you have to know, is it controlled or no? You will analyze the diabetes. So this is the second case or second cause of polyuria. First, we already exclude by constitutional symptoms the polyuria related to the cancer, whatever the kind of cancer. Now you rolled out diabetes from the question of, do you have any past medical condition I should be aware of? Then the next symptom or the next questions will be related to the systemic review. The first question, CNS, headache. Do you have headache? How is your mood? If he said yes, what you will think about? I have low mood. I have headache. Hypercalcemia, right? Low mood, hypercalcemia, right? If you have low mood, this is hypercalcemia, or he will tell you, yes, doctor, as Dr. Rasha said, Dr. Azza said, I have low mood. I am taking medication for my low mood. So you'll think about lithium. This is from the first system to ask, which is the CNS. Let's go to the second system. But before leaving the CNS, you have to ask also about weakness, or you have any change of sensation or vision problem. Why? You might have also neurosarcoidosis, as a, for example, facial palsy, neurosarcoidosis, or any cranial nerve palsy, or even cranial diabetes. If you have the headache, for example, the next question or next system will be endocrine. Any preference or any intolerance to any weather. So this is not related directly to the hypercalcemia. But let's think about the possibility of having endocrine problem in this scenario. Already we mentioned diabetes in the as a past medical history. But if you have diabetes from the question of endocrine, you have to analyze the diabetes in general, either hypoglycemia, if you have what medication you are on, what type of diabetes, and definitely you have to ask about the complication of hyperglycemia, neuropathy, retinopathy, and nephropathy. Don't forget to ask about the hemoglobin A1C. This is if you have diabetes. You have to analyze it totally. But if no, you will go to the next system, which is cardiovascular. Any awareness of heartbeat? No. Any chest pain? No. What do you think if this patient is having chest pain related to the case hypercalcemia, sarcoidosis, signs of heart failure, dizziness? You can think about, but it's not the case. But I'm talking in general. We are opening discussion now. If you have suspected sarcoidosis and the patient is having chest pain and he's having attacks of heart failure episode, attacks of orthopnea, dyspnea, paroxysmal nocturnal dyspnea, cardiac sarcoidosis, infiltrative, restrictive cardiomyopathy, right?
Yes, yes.
Yeah, I'm talking not as a topic for the sarcoidosis. I am talking in general. If you have polyuria and you have other manifestation of the disease related to the polyuria. So we have sarcoidosis, for example, cardiac cardiomyopathy related to sarcoidosis, infiltrative cardiomyopathy. The next system will be the chest, respiratory. Do you have short of breath? Do you have cough? I have cough. I have short of breath. What you will suspect related to the polyuria? What would be? Sarcoidosis, dry cough, short of breath, fibrosis. Now we have either, if you have positive, for example, you will think about sarcoidosis. I'm taking this question in system review because you have to do the systemic review. And whatever you have symptom, you have to think and to roll out or to roll in the cause of polyuria. Sarcoidosis, now we have three symptoms, either neurosarcoidosis, or you have cardiomyopathy related to sarcoidosis, or you have short of breath or and cough related also to sarcoidosis. Now we'll go to the GI. You have any change of the bowel habit, any tummy pain? Yes, I have. It would be also related to the hypercalcemia, either due to sarcoidosis, if you confirm that sarcoidosis from the other system, or no, you can go to the next system, which is musculoskeletal. You have joint pain. Yes, it's sarcoidosis. I have skin rash. Show me the rash, either erythema nodosum as this patient is having, or lupus nephritis if as this patient was having. These are the most common cause of polyuria. Sorry, for the cause of polyuria in paces. Let's repeat them. Okay, we'll start from the head. Diabetes insipidus as a cranial cause, either due to sarcoidosis or due to any brain lesion, tumor, whatever the cause. Cranial diabetes insipidus. The next, diabetes mellitus. Next, sarcoidosis with hypercalcemia. The causes of hypercalcemia, either hyperparathyroidism or cancer, multiple myeloma, and we'll go down to the kidney nephrogenic diabetes insipidus. What the cause of nephrogenic diabetes insipidus? Hypokalemia and hypercalcemia, right? These are the cause of nephrogenic diabetes insipidus. And the lithium and sickle cell disease. These are the cause of cranial diabetes insipidus, and we already discovered all causes of diabetes of polyuria in paces. Is it clear now, Dr. Kinana or Dr. Maisoon? I don't know who asked.
Yes, clear, doctor. Thank you.
Okay, so from systemic review, you can get the differential or the cause or the disease. Don't forget the psychogenic polydipsia. You can get it from the question of how many liters you are drinking, plus he's having background of psychological issue. He will tell you, yes, I have low mood, or I have psychiatric illness, or whatever. But he will be drinking a lot of water. Anyone search how many liters the polydipsia patient drinking? Psychogenic polydipsia? Anyone checked?
6, 7 later.
Dr. Aisha? Dr. Aisha here, she's the one already always updating us about the questions. Anyway, it's a homework for Dr. Who asked for the polyuria approach and the
Me,
differential. Okay,
me.
yes, this is your homework, please, Dr. Maisoon.
Okay, inshallah.
Yeah, just update in the group how many
Mhm.
liters the psychogenic polydipsia patient will receive or will drink.
Okay, shukran. Got it.
Okay, okay. Any other question from others? Any comment? Any suggestion, Dr. Rasha, Dr. Azza?
No, thank you. شكرا.
Okay, most welcome. Thank you also, Dr. Rasha, Dr. Azza. What is this? Someone shared?
Dr. Basim, question?
Yeah, sure.
Shall we put primary hyperparathyroidism as one of the differential?
Okay, what do you think you will
Because
have?
it's the most common cause of hypercalcemia.
Okay, what do you think you will have as the symptoms if you have hyperparathyroidism, primary hyperparathyroidism? In cases.
All symptoms of hypercalcemia.
Only symptom of hypercalcemia, but this is not the case. It will not come as only symptoms of hyperparathyroidism. It will come with another disease.
But you put malignancy, and also there is
No,
no other
listen to
causes
me.
of malignancy in the differential.
Yes,
And you
yes.
put psychogenic polydipsia.
Adenoma is not cancer, right?
No. I mean that we can put primary hyperparathyroidism.
Yes,
And
sure.
instead-
It's one of them. Yes, it's one of the hypercalcemia causes, hyperparathyroidism.
And the most common cause of hypercalcemia, not only
Perfect.
one of.
Yes, you're right. Yes, I didn't mention it. Yes, you're right. One of the causes, yes, it is hyperparathyroidism. But the case will not come as hyperparathyroidism alone. What do you
Totally
main
think?
one and main two.
in our
Main
case,
one
what is
and
the differential? يعني in order
Yes,
from 1 to
yes,
3, what is
yeah.
are the differentials?
No, they will not bring hyperparathyroidism alone. You know why?
No, I mean in our case today, what is the
Yes,
differential?
the differential in our case, the lithium
Yes,
as nephrogenic diabetes insipidus or sarcoidosis, and this is the
I
case
think
because there is
sarcoidosis is number 1 and then the lithium.
sure
But the lithium does not explain the lipaspermia and the erythema nodosum also. So
yeah,
we
but you
can
have to
put
think, you
primary
have to put it.
hyperparathyroidism because it's the one of the most common causes of hypercalcemia.
Okay, but in the exam, you will not say this is the first or the top of differential. The top of differential in this patient is the sarcoidosis, second differential, lithium, because you have positive finding. But you cannot say hypercalcemia. I can think about hyperparathyroidism, and you have all these symptoms, right?
So I will put it
Hyperparathyroidism,
before malignancy, maybe for malignancy.
you will not say malignancy in this scenario, right? You can say
If
psychogenic
the examiner
polydipsia.
asks what else, what
So
shall
psychogenic
I?
polydipsia, you can say psychogenic polydipsia. Patient is drinking out of water. He's having background of psychological issue.
Mhm.
But
Okay.
primary hyperparathyroidism, you can put it as someone
If
said
he asks
now.
about causes of hypercalcemia itself.
Yeah, it's in logic. Yeah, logically, yes, it's
Yes.
one scientifically, it's one of the cause of hypercalcemia. But in this scenario, I cannot say this is
Yes.
hyperparathyroidism. Why? Because I have a known cause, sarcoidosis. I have, and
Related to the case, yes.
even you
Yes.
can put sarcoidosis as hypercalcemia. You can put sarcoidosis as the cranial diabetes insipidus, right? Sarcoidosis infiltration in the brain will lead to psychogenic, cranial diabetes insipidus.
Yes, that is why they said sarcoidosis cause
Exactly.
hypercalcemia symptoms in many forms
Perfect.
by attacking
Yes.
the brain itself or the kidneys.
Yeah. So you have two differential now from sarcoidosis. You can put them, you can get the full mark. Then
Okay.
you can put the lithium. But I will ask you, doctor, one of the doctors, I heard it, but I want you to say, if you have in the PACES exam case of hyperparathyroidism, what other manifestation you will have with this patient? Or what the case will
Patient,
be?
Hypercalcemia.
I think renal stones,
Renal
maybe.
stone.
Okay, this renal stone, okay, can be, but what the
Men.
case would be? Yes,
Men.
exactly. This is what I want to, yes, main one.
Yes. Men
So
one.
pituitary, you will have pituitary adenoma,
Yes, pituitary. Yes.
And bacteria.
hyperparathyroidism, and pancreas. Yes, exactly.
Yes.
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 So it will not come alone, hyperparathyroidism alone. Should be with either main one as parathyroidism itself, or the polyuria related to what we mentioned already. This is the
Or as
common,
a complication of chronic renal disease. Yes.
could be, yes, you can say as a renal stone, and okay, can be. Yes, you're right.
Mhm. Thank you, Dr. Basim.
Okay.
Thank you.
By the way, there is also, most welcome, there is medication can cause hypercalcemia. You have to ask specifically in the patient, anyone knows what medication can lead to hypercalcemia? And it could be the cause of hypercalcemia. It could be the case. Patient non-hypertensive.
Calcium and
Uh,
vitamin D
Yep.
and the phosphate
That's
binder.
Mm.
oh, it came before, yes, hypervitaminosis D cause hypercalcemia. There was patient taking vitamin D supplements for long time, and he had hypercalcemia. But it's very rare. It came before. So hypervitaminosis D. What else?
Yes.
There is medication common for hypertension. Patient with
Thiazide.
hypertension taking, yes, thiazide.
Thiazide.
If you
Thiazide.
have,
Eric.
if yes, thiazide can lead to hypercalcemia. If you have patient with hypertension along with this manifestation of the disease, sarcoidosis, and he told you, doctor, I am hypertensive, you should ask about any medication you are taking.
I think
They
also
might
over
tell
the
you,
counter medication for antacids also one of the causes of hypercalcemia.
yes, but yes, you're right, but it's not common in cases. But you have to think about if he has acidity, for example.
Yeah.
But the common is common. What I mentioned are the common in cases: cranial diabetes insipidus, psychogenic polydipsia, the hyperparathyroidism, cancer, sarcoidosis, nephrogenic diabetes insipidus, diabetes mellitus. There is approach for the polyuria. I will post it in the group now. Okay.
Yes.
Any question or suggestion? Okay, Dr. Aisha updated us exceed 3 liters, but usually 5 liters or above in the
Yes.
scenario. Yeah. Thank you, Dr. Aisha. Yeah, very good, Dr. Aisha. Thank you. The inflammation, I agree also to say inflammation or to say unknown cause. Constipation, not complication. With constipation, constipation is association, not complication. Constipation is one of the manifestation of hypercalcemia. You might have it. Most probably, you will have constipation. Okay. Thank you for the participation today, Dr. Rasha and Dr. Azza. Thank you for the discussion. Also, Dr. Maysoon, Dr. Kinana, Dr. Aisha. Thank you, everyone. I hope I didn't miss any of you.
Just
Any
I'll add
question?
a question of lithium. Lithium, you should, if you
Yes.
hear about lithium for any patient, you should ask what last time you checked the level, because they regularly check the level of lithium,
Perfect.
especially when it started. And lithium also has GIT symptoms of toxicity. So you will
You're
suspect
right.
if he has toxicity
Diarrhea.
from lithium. Yes, he will have GIT upset and diarrhea.
Yes. Always you are putting your touch
But
in the case. Thank you, Dr. Aisha.
mashallah, Dr. Azza and Dr. Rasha, both are mashallah excellent. Yeah.
Yes. Thank you, Dr. Aish. Thank you for the comment. Any question before ending the session? Okay, see you tomorrow, inshallah, at Communication Day. The same time, 10 p.m. KSA. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.
شكرا.
السلام عليكم.
Salam.